presentation. We're now going to give the same opportunity to what I'll call our consolidated model colleagues. And I'm not sure who's going to kick off. So Dr. Brar. Dr. Brar will begin and introduce his colleagues through the presentation. And we'll then follow that with some clarification questions and answers.
Good evening, everyone. My name is Parminder Brar. I'm the Regional Chief of Pediatrics for the Niagara Health System and have been since the year 2000, since we all got together as one happy family. We're going to take a slightly different tack in how we make our presentation. I'm going to, in a minute or two, hand over to Dr. Villian to lead our presentation, which will be up there for everyone to see. And Eric and I will jump in as needed to complement his presentation. But I wanted to start off by acknowledging the great job that my peers and colleagues across the aisle here have done in terms of raising the issues, which are very pertinent, some legitimate, some perhaps less so, and highlighting the problems that have existed in the Niagara region for the past several years with the way we've been doing things, and which has in fact driven us to try and consolidate in the first place. They have done this for the betterment of what they perceive as the safety and accessibility of their patients, out of a real concern for the patients, not for personal goals, and I applaud them for that. I think in highlighting these problems, they have raised issues which we are still struggling with. However, this is not something new. We've been doing this for over 10 years now. And I'm not surprised that they are well versed in all these issues, because we've sat down many times together and discussed these over the years. We worked as the maternal child program, which involved the site chiefs of pediatrics and obstetrics, as well as the administrative components of the program over the past few years. We all acknowledge these problems. I think where we differ is in how we go about addressing these issues. And I think rather than take the approach of trying to dispute point by point what my colleagues have said, I would refer the panel to the Case for Change document, which I'm sure they've been provided, and if not, they can be provided, which addresses all these issues that my colleagues have raised, and the program's approach in terms of how to deal with them. The only other point I'll make before we start a presentation is that the comment was made that perhaps folks who should be dealing with this are perhaps people who have dealt with it on an individual personal basis, and perhaps the tertiary care centers are not necessarily aware of conditions in the in the community. To that, my only answer is that the model proposed by my colleagues was addressed by the MAC, which is comprised entirely of the medical staff, leadership of the Niagara Health System, and was considered in detail. We spent well over 2 hours discussing it, and I believe almost a direct transcription of what was said is available to you if desired. And after due consideration, it was found to be unacceptable by our own peers, our local leaders here in the community, for reasons that are best addressed in that minutes of that meeting. But I just wanted to point out that those folks are from here, local people with local expertise, dealing with community issues, and are well versed with them. So I'm going to hand over to Dr. Villian to get us going, and I'll jump in when needed, and we'll be happy to answer questions later. Thank you.
Thank you very much, Dr. Brar. I'm Villian, as we've met before this evening. I'm the Regional Chief, currently and have been since November of 2006. As Parminder said, the concept of a single unit for obstetrics and babies is not new. When the Niagara Health System came to being at the very first regional departmental meeting of the obstetrics section, a unanimous motion was passed. And all those members are behind me. A unanimous motion was passed requesting the NHS to seriously consider the creation of a single obstetric unit. our program, I'm quite proud to say, and all of those members are behind me, and all of them have worked, many of them have worked with us on the case for change that you saw. We created a program management and planning committee, proactively been working, and as you will see when you go through that document, no stone was left unturned, including very detailed mapping of time and distance and travel times and correcting for traffic patterns and weather patterns, etc. So I'm proud to say we really looked at it thoroughly. There were occasions that external reviewers were invited into the NHS. We took their recommendations on board. And that brings us basically to tonight. We all know what Dr. Smith's recommendations were, what we should be aiming for. And I sincerely believe that amalgamating our services on a single site, and I have no preference for where that site were to be. It just so unfortunately happens that a perfect storm created the only available appropriate space in the new building where it is, and we can't move it, unfortunately. So, is there a reason to consolidate? Why? Yes, I will try and point out what I believe would be factors that could allow us to improve our quality of care. I want to acknowledge that all my colleagues in all three sites have literally worked their fingers to the bone. However, it is our duty to continue working on improving quality. We cannot just function on the legacy of how we've done it for the last 2.5 generations. It is always our duty to improve. Expectations have changed, and Dr. Leland has stolen some of my thunder about the upcoming generation, but we'll go over that again. So expectations have changed from the viewpoint of providers, from the viewpoint of people who receive care. I believe we can address patient safety on a number of levels. We certainly can optimize the human health resources, and we can improve the quality work environment. And unfortunately, we do live with fiscal realities. We are constantly being charged by our federal and provincial governments to be turning over every penny. I remember a former leader in our organization very exasperated one day telling me that we are constantly being asked to do more and more with less and less until we'll do everything with nothing. And sometimes it does feel that way. So yes, we are patient-centered, and that is very important, but there is a fiscal reality that we need to look at. And I believe a single model does address that to some degree. I'd like to pass over to Eric Dissett for his perspective.
Thanks very much, Dr. Brilliant. Good evening, members of the expert panel. Good evening to distinguished guests. Good evening to my colleagues and to all those who might be viewing this presentation. I am a nurse by profession, and my professional passions include patient-client-centered care and interprofessional practice. As many of you know, the NHS is very much on a new path. Our vision, Together in Excellence and Leaders in Healthcare, sets the stage for rethinking about the delivery of women and babies and children's health. The consolidated approach is very much in keeping with our vision and our two strategic objectives, namely improved patient experience and improved staff and credentialed practitioner satisfaction. The NHS has two critical success factors which align with our vision and the consolidated program approach. The first is to focus on those we serve, and the second is to bring out the best in each other as staff and practitioners. In a consolidated program approach, patient-client-centered care will facilitate our ability to keep our eyes on what's important, our patients, and what's most important to them, their families. Implementation of interprofessional practice is designed to ensure that all professionals are practicing to full scope and to ensure our patients receive timely and skilled access to care without undue delay. A consolidated program approach is a new way of thinking about care delivery. It's one which celebrates embracing patients as partners in their care and understanding what's most important to patients. It brings to bear the full expertise of the interprofessional team in a way that transcends the classic multidisciplinary care approach, in which professionals offer discipline-specific services in parallel. Like all new programs, like all new approaches to care delivery, a consolidated program approach will require all of us, as partners and as key stakeholders, to understand the change process and to take our rightful place as it relates to leadership and coaching the new way. It's a way that takes its roots in evidence supporting interprofessional care, the World Health Organization's interprofessional education and interprofessional practice framework, and our own Ontario blueprint for implementing interprofessional care in Ontario. So in a consolidated program, what's our commitment? What's our care promise? Our care promise to patients is more integrated family and community health. It's caring for the whole person. It's about collaborative practice and having a ready workforce. It's about having the right people in the right place at the right time to deliver the right care. It's about promotion of full scope of practice. It's less about what makes practitioners different and more about what makes practitioners similar. And where then do patients have the benefit of overlapping scopes so that service is timely, it's competent, it's evidence-based, and it's provided in an integrated manner. The challenge, I think, before all of us is that we have health system pressures. Those pressures are about timely access. They're about finite human resources. They're about finite financial resources. The new way, or the consolidated way, is patient-client centered. It embraces interprofessional practice, and the outcome will be an improved patient experience, positive health outcomes for patients, and patient safety at the forefront. The consolidated way. Think about these important essential maternity care services for all communities. Early and regular prenatal care, postnatal care, lactation support, bereavement services, hospital birthing services, level 1 including anesthesia and surgery, timely stabilization and transport to and from more advanced care settings, perinatal psychiatry, and mental health services. These are but a few of the many local health needs. A consolidated approach in which a program of excellence is at the center of care, bringing to bear interprofessional expertise in tandem, offers our patients a complete, integrated, comprehensive, and evidence-based service. That's why we have chosen to use the adapted WHO framework, World Health Organization framework, for interprofessional education and collaborative practice. The framework is very evidence-based. At the heart of the consolidated program is a total commitment to interprofessional education, where all professionals have the opportunity to learn from, with, and about each other. The physician, the social worker, the childcare worker, the dietitian, etc. all need to understand the importance of breastfeeding and the signs of failure to latch, and ensure moms and babes are getting the appropriate services, and actively resist the temptation to consider that only that is within the scope of nurses. IPE occurs in everyday exchange between professionals. It drives professional knowledge. It builds competence. It supports relationship development. It facilitates leadership. It creates accountability, and it promotes ethical practice. IPE helps to facilitate patient-client-centered care and collaborative practice. A consolidated program builds in the necessary structures and processes, which Dr. Villian and my colleagues will talk about, to ensure a more integrated health system for moms, for babes, for children, for families, and for our communities. How should the needs of a 6-year-old boy with behavioral problems or with a mental health diagnosis be best cared for? In a fractured, disparate system, or in an integrated system where access to full interprofessional practice team is readily available, inclusive of the expertise of on-site mental health staff? All of that builds an integrated system with positive outcomes. So let me share with you a couple of examples. Improved experience, pediatric surgery. Imagine a situation in a consolidated program where the team engages parents and the child as partners in planning and evaluating care from admission through discharge, where the team ensures that the 8 dimensions of patient-client-centered care, access, emotional support, physical care and comfort, information and education, to name 4, are being consistently addressed. Where the team looks for opportunities for shared scope to improve access and service, to ensure the best possible outcome for the child, for mom and dad and the family, respecting the uniqueness of their situation. Imagine the child life work or the social work or the physician, the dietitian, the lactation consultant, all of whom play a role in a comprehensive integrated model. What about the lactation experience? What might that look like in a comprehensive consolidated model? Certainly the team engages the mom, dad, and baby as partners in planning and evaluating successful lactation. The team ensures that patient satisfaction dimensions such as access, etc., as I've mentioned already, are consistently addressed, and the team provides and ensures access to lactation consultants. Surely this has got to be good for babes. This has got to be good for babes and mom. This has got to be good for families, and it's got to be good for our communities. So as I hand the presentation back over to Dr. Villian, I would encourage every one of us here this evening to reflect on the following World Health Organization quote, and I quote, "Maternal and child health are essential to the overall well-being of a country. Every day, 1,500 women worldwide die from the complications in pregnancy or childbirth. Health workers who are able to jointly identify the key strengths of each member of the healthcare team and use those strengths to manage complex health issues of the entire birthing family will play a key role in reducing these alarming and preventable statistics." End quote.
Thank you very much, Erin. I think those are certainly poignant words to listen to and to take to heart. And certainly, I believe that no matter which model we go with, underlying each of us, those values should hold true. Let's look at critical mass. Unfortunately, single numbers are bandied around as the unit should be this big and that big and up, and that there is no true link between numbers and quality of care. And sure, the data is sparse. But I believe there is strength in numbers. In all 3 units at the moment, we are minorities. We're a small part of the puzzle. We are easily pushed around. As a regional chief, my desk is the complaints desk. I very frequently, and more frequently than I wish to, get a phone call from a colleague of mine complaining about having been bumped. I was pushed out of the operating room. I had to wait 2.5 hours with a lady who is in agony, where the anaesthetist has tried everything to keep her pain under control with an epidural, and she really needed a cesarean section because she hadn't progressed for 6 hours. When I discussed that with my surgical colleague, I was just bullied out of the way, and my patient had to wait. The smaller the unit, the more that's going to happen. The other typical complaint I get from the smaller unit is, I had to make 14 phone calls to get a surgical assistant to help me with an emergency cesarean section. There is strength in numbers. If we work in a unit where we deliver 3,000 babies, we have a claim to stake. We have the right, we've earned the right on behalf of our patients to say, we don't accept that kind of treatment for our patients. We do deliver this number of patients. We do expect that our patients' needs will be responded to in a timely fashion. So as critical mass goes, I don't think it's the number and the safety, I think it's the fact that a critical mass affords us that possibility. As regards physician recruitment and medical education, I think the two tie in very well. Dr. Leland has alluded to some of those issues. We are a satellite campus of the Current Medical School. As such, we do have a responsibility. We have a responsibility in teaching undergraduate medical students. We teach residents, but practice more so. And we have had the privilege of having had senior PGY4 and PGY5 residents here. And we were able to give them a fairly good experience. However, each individual site just does not have the volumes that allows these learners to really draw out of this experience what they could draw out of the experience. Certainly critical numbers will do that. The other part of the education, if we are able to provide our learners with a very favorable and pleasant experience as a learner, they will be much more inclined to want to stay in this community. That goes for the clerk who would like to do a residency here. It goes for the family practice resident who would like to stay here. And it certainly goes for the PGY 4 and 5 who would like to come here and practice with us. And I believe that is one of the most successful ways that you could ever get recruitment to happen. Because it works both ways. We get to know that resident. We know how the fit is going to be. And we've got somebody who knows the community, likes the community, and is certainly going to be an asset to our environment.
I'm only going to echo some of what Dr. Williams said, but perhaps with an example. In terms of physician recruitment, several years ago, when there was only one pediatrician in Welland, we were able to help cover that till we managed to get a few more. I would like to, however, remind you that the people that we recruited were primarily IMGs who were fast-tracked through the system. At present, out of my department of 12 active members, 6 are IMGs who were fast-tracked into the system. In fact, if it weren't for those folks, we would have had to close the other 2 hospitals long ago. Welland right now has only Dr. Bonsu as the Canadian trained physician there. The others were fast-tracked into it. And Niagara Falls only has Dr. Bagrat. The other gentleman was also fast-tracked into it. Can we continue to hope for that? Probably not, because as of now that I'm aware, that fast-tracking is no longer existent. People have to do a couple of years of local residency training before they can. In terms of medical education right now, we only have St. Catherine's taking a family medicine resident. The other 2 sites do have students. It is envisaged that if we are able to get to one place, having spoken to Dr. Stobie, the Dean of the McMaster campus here, he would be willing to try and get us 1 pediatric resident, 2 family residents, and 4 clinical clerks to be with us 365 days a year. A substantial increase in the learners that we would be able to accommodate should this come about. The other point that you see there is additional services mentioned there. In terms of critical mass, right now we don't have enough of a critical mass to be able to engage in things like neonatal TPN and also mechanical ventilation even for short periods of time. We've made some strides by adding the capability of nasal CPAP at all 3 sites at this time. But in future, we would hope that in one place we would be able to go even beyond that and not only offer neonatal TPN, but also to do short-term mechanical ventilation at our one consolidated larger unit. This will help in decanting earlier some of the patients from the NICU in the region, which are always overloaded, as I'm sure you are always aware, and we are always being asked to accept more and more folks. So I just wanted to point out that critical mass does matter, and that is something that will come about only in consolidation.
Thank you very much, Dr. Brown. And continue, we've covered most of what I wanted to say about the culture in different units. And my biggest concern there was that due to the size of our units, we are often very low on the totem pole. And that's definitely something I would like to see reversed. Standardization, that's one of the buzzwords in medicine today. We know that it's very important that we work with order sets, that we work with protocols that are tested in evidence as far as evidence base is available, wherever it is available. Very difficult to implement that on 3 sites. We have tried that with some limited success, but again it seems that the legacy takes over more often than not, and we don't seem to be able to work that into practice pattern very well. That certainly would be made very easier if we all work under one dome, when there is transparency in what we do, that standardization with regards to who do you induce and when do you induce them, what kind of protocols do you use, and what safety measures do we all follow. Equipment is certainly an issue. It's an issue for everyone. For many a year now, we are reliant on the extra bits of equipment that we wish on our foundations. And And our foundations literally bend over backwards, and they have to be applauded for what they have been able to provide us. But they have just not been able to provide us with everything. A simple example. In one unit, we have an on-site, in the unit, ultrasound machine. Patient comes in, you're uncertain of the lie, we're all trained well enough to put the probe on the belly and you can see it's a breach or not. Makes a huge difference in the management and a huge difference with patient safety. Simple as that. The two other units, we've had it on the capital wish list for as long as I care to remember. We just seem not to get there. In a single unit, you obviously only need one ultrasound machine. That is but one example. There are other examples like that that we could mention. Competency. With regards to physicians, midwives, and nursing, first I'd like to address the physician issue with competency. With a bit of an angle. About a year ago, I asked members of my department to answer a survey for me where we discussed the proposed on-call model, amongst others, assuming that we have a single unit. And I'll get to what came out of that. But I also, in that same survey, asked them, what would you see we could develop if we were a single unit? And very interesting ideas came forth, which again underlined to me the desire of my colleagues to be in a single unit. Having a dedicated clinic for diabetics in pregnancy, having a dedicated clinic for urogynecology. We have people within our department with special training and published, people who have published in our department, that at the moment, because everything is scattered and we don't have those critical masses and numbers, it doesn't make sense yet to have such a clinic. That could very well be so. Those were two options. We certainly looked at a postpartum clinic to manage depressive disease. So there are a number of very needed entities that we could address if we have critical numbers. Midwifery. That has been a bone of contention since our midwife colleagues joined us. And there's always been the issue of scope of practice and being able to practice to the full scope of practice. And the outstanding issue, which has led to the differences that you will see in how many midwifery patients deliver in the various units, is the use of oxytocin in labor. The one unit absolutely refuses to do that on account of the fact of liability. And the liability comes from the medication being provided and the physician not being on site. If we have a unit where there's always an available obstetrician, that will disappear. We can certainly see an improved working relationship with midwives, which I believe is essential. I would want to create an environment, and it's a beautiful one, you'll see some pictures in a minute, where our midwifery colleagues and their patients wish to come and deliver without our interference or intervention. But if we are needed, we are close at hand. So I do believe that we can bridge some of the gaps that have been between us and the midwives very well with regards to their scope of practice. With regards to nursing, our new environment would allow us to teach our nurses new competencies. In the St. Catherine site, we are used to being assisted during cesarean sections by the nurses who took care of the patient in labor. They're trained to do so, and they do so well. We're currently busy training the nurses from the other sites to be able to do the same thing. So nurses will certainly see their competency rise, their own job satisfaction should rise with that ability. There are other options that we are going to explore with the Department of Anesthesia. Currently, we rely very heavily on an epidural service. We all know that in units much smaller than ours, using PCA pumps and using PCA fentanyl and other forms of patient-controlled anesthesia and analgesia is very common. Again, given our newer facility with the layout of the rooms and what we have available in those rooms, there is a willingness with the Department of Anesthesia to explore that. Another competency that our nurses will be able to gain and our patients will benefit from. If we look at the population, the birth rate, you will see that we obviously live in Niagara. We've seen that it's a steady decline. It's a decline that is mirrored in the rest of the country. Stats Canada 2 years ago said the average family was 2.3 children. Stats Canada now says it's 1.9 children per family. So we see that decline, and there's no dramatic reason to believe that that is going to reverse anytime soon. We hear about growth on the Niagara Peninsula. The studies that I have seen with growth is, yes, there is going to be growth. Somewhere from about 440,000 now to somewhere over 500,000 by 2026. But most of those are people who are not going to have children. We know that Niagara is a economically challenged area. There's not a lot of employment opportunity for those people who do have children. And those are the people between 15 and 45. So we do need to realize that those numbers are going to decline or at the very best stabilize. So whatever we plan with regards to what we do, if one were to consider maintaining more than one unit, the other units definitely run the risk of attrition over time.
Just want to bring you up to date in terms of the current state of affairs with the different departments. Right now, as far as pediatrics is concerned, there are 23 beds across the 3 sites which are staffed and in operation. There's more physical capacity, but staffed and in operation, there's 23 beds. And utilization is only at 52.8% at this time. Obstetrics, there's 28, and you can see that they have a higher utilization of 75%. Newborns, there are 29 bassinets, which includes the bassinets out on the floor with the mother, as well as the special care nursery in Welland and Niagara Falls, but not St. Catharines. And that utilization is 52.3%. And the reason why we separated our special care nursery in St. Catharines is only because the CIHI data only recognizes at this point St. Catharines as a level 2 nursery, even though Welland and Niagara Falls function at the same level in terms of care. But we do not have the ability to extract that data from the rest of it.
As Dr. Barada said, you see our bed occupancy is above 75%, and I am led to believe that a unit is regarded as functioning very well if your occupancy hovers around 75% all the time. The reason why we are sometimes 75% and above is we accept post-surgical patients, clean post-surgical patients into our units, and it's not all obstetrics that you will see there. If we look at patient safety, infection and infection control is a hot topic, and anybody who lives in Niagara does not need to be reminded about that at all. Currently, in the 2 smaller sites, you can see the ratio of washrooms to patients. All 3 sites, as you know, are old buildings. They were not designed according to the standards of the day, and certainly not according to the standards of the building we're going to be moving into, and any building that will be built 6 years down the line. 2 smaller movements require that patients be moved from an obstetric unit through public areas and up to a remotely located operating room. In St. Catharines, we do have the distinct benefit and luxury of having 2 cesarean section rooms within our site. In the new site as well, we will have on our unit at least 1 negative pressure isolation room out of the 18 birthing rooms that we have. The new site as well, from a physical perspective, certainly has everything custom made in a 50,000 square foot unit that we could possibly wish to have. If we were to want to bring the Greater Niagara General Welland sites into operation with ORs to address some of these issues, there's a significant cost factor. In late 2006, early 2007, just after I had taken on this position, we did actively explore that. And in terms of those dollars back then, we were looking at $250,000 to $300,000 per site to get an operating room functional. So there's a significant cost associated with that. Obstetrical bypass.
If I can just add something before you go on to that, Johan. In terms of the negative pressure isolation rooms, you mentioned the obstetrical ones. We will also at the new site have 2 negative pressure isolation rooms in the neonatal nursery and 2 on the pediatric floor as well.
Much was discussed about obstetrical bypass, and that certainly has been at times the bane of our existence. Obstetrical bypass has had to be resorted to over the past 5-6 years. Sometimes on account of a physical plant malfunction, if there's a steam breakdown in one of the smaller units or some physical plant issue. Very rarely on account of the inavailability of physicians. Very rarely. Mostly on account of the inavailability of nursing staff. Just to try and explain to you how precarious it can be. One nurse calling in sick, whether it be Holland or GNGH, one nurse calling in sick jeopardizes the staffing model and can lead to the NICU needing to be closed. If we close the NICU, we have to close obstetrics, we have to put obstetrics on bypass. If we put obstetrics on bypass, we have to inform the entire world. The EMS needs to know, the emergency department needs to know, the receiving hospital needs to know. Now, the one statistic that often gets lost in the woodwork is the number of times we avoid bypass. I cannot tell you how many times on a Friday morning or on a Friday afternoon at 3 o'clock, all of a sudden, we find out that the 7 p.m. shift cannot be covered in the site. You have no idea the work that our nursing leadership at that time has to get to. Bypass is inherently something we need to try and avoid at all costs. One of the issues with bypass, whether it's a planned bypass or an emergency precipitated bypass, is communicating to the public. It's very difficult to do that very efficiently and make sure that every patient and every member of the public actually knows that. I find it can be a very confusing and very dangerous situation to have. There's also costs, obviously, associated with bypass. Once you close down an ICU, it means babies are already in the ICU, they need to be transferred out. We have limited equipment with which to transport these compromised infants. We are then taking an EMS service out of commission while all these transfers are happening and they cannot respond to the emergencies. And the EMS department has been very clear in their concerns about the concept of bypass, whether it's those that we do caused by emergency or those that we could in future do in a planned manner. The 24/7 on-site obstetric call, part of the survey that I had mentioned to you previously about physicians wanting to create specialty clinics, they were also asked how would you see the on-call schedule working in a single-site model. And again, of interest of 14 members, 13 responded. And again, their response to me signals they gave it some thought. And if you respond and give the call schedule a thought, it means that psychologically you've accepted the fact that you're going to be in a single site. And I don't think that should be lost. The physicians all chose an on-site on-call model as compared to what we have now. There was a significant number of physicians that actually suggested a 12-hour shift on-call rather than an onerous 24-hour shift. So what are the benefits of being on-site? The benefit of being on-site, firstly, goes to the patient. When the patient arrives, again, what you had addressed previously, the team is there. The obstetrician is there. There's no travel time for the obstetrician. There's only travel time for the patient involved. Yes, I understand there are potential issues with travel time no matter which way you look at it. We acknowledge that, but the team is there and ready to react. The other benefit is that the physician who is on call for that 12 or 24 hours focuses on nothing else. This is my duty and my responsibility right now. What's happening in an office is not an issue. I'm not worried about, oh dear, there's a waiting room with 15 angry ladies and getting angry by the minute waiting for me. I need to rush this delivery and do an operative intervention that is is actually unnecessary because I'm going to try and make it back to my office because I don't want to disappoint those 15 ladies. And the same is the other way around. If you're in the office but you have somebody in labor, that same concern is there. You know, that fetal heart rate. Should I be there? Should I be here? It takes that away if you're on site on call. If you have a group of 12 or 14 physicians, that will make for a very manageable on-call system. Our department has also fully recognized that not only do we have a responsibility towards a single site where we do the active obstetrics, we fully realize that there are 2 other communities with emergency departments where the luckily very rare severe emergency can present and will need care. Now we look back about a year ago at the statistics for specifically ectopics, and as you've heard, we have thousands of ED visits per year. And over that 1 year, there were 47 ectopics that presented in the 3 sites, 47 for the 3 sites. Of the 47, only 1 was hemodynamics, so very unstable, and by pure luck, the gynecologist was on site when she presented to that site and she was operated within an hour, by pure luck. Because remember, we do not take call on site, we take call from home. So the emergencies are few and far between. So our department will definitely be looking at a second on-call that will provide service to those departments, understanding that we will not be abused, understanding that we won't have any cry wolf situations, that we would call for the true dire emergencies. So the ED departments in the smaller units will not be left out on a limb. With regards to anesthetic, so with regards to the anesthetic and pediatric backup, the question is easy. You as obstetricians can offer the 24/7 on call on site. If you don't have the pediatrician there and don't have the obstetric, have the anesthetist there, then the plan has a hole. The Department of Anesthesia cannot provide a dedicated anesthetist to us. There were also cite numbers from the Canadian Society of Anesthesia that suggests that if you have a unit smaller than 4,500, that you do not really justify having a dedicated anesthetist. However, the Department of Anesthesia, who does Lions work for us, completely understands response times as has been made clear by the SOTC. They understand that and they agree to provide access to us in 30 minutes or less. One would wonder over time if you have a single unit that one may quite quickly see that to be able to deliver that kind of access, that an on-site arrangement may be necessary. There was the question, and I can only partly speak for the Department of Anesthesia, and they can kill me later if they so wish, but the Department of Anesthesia, as I understand, is just as regional as the rest of our departments. And I believe that there will be thought given to a mechanism where anesthetists from the other sites who wish to maintain competence and an interest in obstetric anesthesia will be able to join such a call rotation. There is no reason why that could not happen. And I am sure, knowing the leadership in the Department of Anesthesia, that those options will at the very least be explored with seriousness. Dr. Broad can speak about coverage for pediatricians.
At this moment, as my colleagues mentioned, there is no clear-cut defined plan in terms of how we will approach our call schedule. There is certainly a proposal that we have developed that is before administration at this time, which would provide, if accepted, as presented, and that's all I can say, as presented, then we would have basically a pediatrician on site at this time, but there are some hoops to work through before we achieve that. The question of coverage for the other 2 sites, if there is some unforeseen eventuality there, is being also looked at by considering a second on-call pediatrician whose sole responsibility would be to cover those 2 sites if needed, either on the phone or in person, with the caveat, as Dr. Villian said, that we will not be abused in utilizing that to cover each and every little thing that happens at the other two sites. So that's being worked out. It is something we acknowledge that is present, but I'm sure it is not an insurmountable thing. And I'm sure the administration is just as motivated as we are in trying to address that issue.
Thank you very much, Dr. Brar. I just a few minutes ago mentioned to you that Niagara is in an aging community. Well, guess what? We are part of that community. Nurses and physicians alike. If we can, I'd like to move on to that. Nurses and physicians alike. You will see the eligibility to retire amongst our nursing staff is quite significant, which I do not think will make our staffing issues at 3 units any better. And certainly, being able to move to a single unit, we were able to bridge that a whole lot more successfully. Physician demographics. I'll speak to the obstetricians first, and I'll allow Dr. Brar to talk about the pediatricians. I mentioned to you that there are 14 hospital staff. 70% of the 14 are 60 or older. So as much as we are planning from now, I think it's our responsibility to look at 5 and 10 and 15 years into the future. And we are going to be very dependent on the Gen X and Gen Y. We are very dependent on a demographic that looks at the world much differently than we do. I mean, my colleagues in Niagara Falls, I mean, they're unbelievable. We will not see anybody in the upcoming generation ever willing to work like that. Practicing in groups is very much the new trend. We also see in medical schools and in residencies that a very rapidly growing percentage of residents are female. Females have unfortunately, because they are the members of our society who are going to have babies, they have different needs as well. Needs that we need to appreciate. We need to make it possible for them to be able to function, and we need to be able to make it possible for them to have a family life. So many of our female colleagues will often ask me about what are the options for job sharing. But the moment we talk about job sharing, you're looking at 2 people to fill the role of 1. So demographics definitely is not on our side. If you look at 70% out of 14 people being 60 or older, you can anticipate that 5, at the outside 10 years from now, there's going to be a mass retirement, or people's health profiles change and they step away from practice. So we do need to position ourselves in a manner where we can recruit to an environment where we will get interest to come and work here.
The story is not that different for the Department of Pediatrics either. We are 12 members. 3 out of the 12 are, or will be within the year, 60 and older. Another 2 are in their mid-50s. And the remaining are basically in their 40s or late 30s. So fully 50% of our department are in their 50s or more. With having to get up in the middle of the night and so on and come and attend all of these deliveries and emergencies, it's not all that palatable to many of the newer generation. Also the feminization, if you will, of pediatrics leads to some similar concerns in terms of staffing that Dr. William has already addressed. I'd also like to talk a little bit about the nursing demographics in terms of staffing for a pediatric ward and special care nursery. As you can see, 70.5% of the special care nursery staff, nursing staff, are eligible to retire now, not in 5 years, now. Will they retire is up to them, but they are eligible to retire. Right now, in Niagara Falls, for example, it's a somewhat removed unit from the rest of the pediatric ward, so it's very difficult to staff. As Dr. William mentioned, 1 nurse calls in sick with an hour or 2's notice, and we are in catastrophe mode in terms of trying to arrange a bypass. And you can imagine what will happen if all those ladies decide, and 1 or 2 gents, decide to retire in the very near future. By consolidating, we will have more of a larger sort of nursing pool and less likely that we will be left out in the cold from somebody calling in sick or otherwise.
There's been some discussion about the quality indicators. The quality indicators I've indicated to you there are the ones that are publicly visible. They are published regularly, and any member of the public can look at those. The reason why I'd like you to look at those is, for the greater part, our system is doing quite well. Our total cesarean section rates are definitely below the provincial benchmark. However, we have a unit that is an outlier, that, as you will see in your package, has a cesarean section rate that sometimes approaches 40%. So we have work to do, although as a system, we're looking well. Primary cesarean section rates are under provincial benchmark, and that's where we can make a difference. And that's where a concerted effort needs to be done with regards to inductions. Because as inductions go, we're a dramatic outlier. There are units and there are individual physicians with induction rates 3 times the provincial average. So that needs to be addressed, and we can address that, certainly much more effectively so in a single unit. We also will see that there are units with lower cesarean section rates than others, but if you carefully look at some of the tables, you will see that there's a flip side to that coin. That in those same units, there seems to be higher rates of trauma related to instrumental delivery. So those statistics are out there, they're there for the public to see. We are aware of them, and we need to address them. And we feel that everyone working in one unit under one transparent dome, we have a far better chance of addressing those issues than trying to continue with 3 separate units. Work environment and culture, improved call schedule. We've discussed most of these issues. The one thing that, with regards to culture, that I still want to mention, there is a fair amount of evidence in the literature that if you work with learners, the quality of work and safety in any unit improves. I think most of us who work with learners have noticed that we are far more careful what we say, how we say it, what we do, and how we do it. And that has been well proven in the literature. That permeates through, and that sort of cross-pollination within a unit is one of the most effective methods of increasing quality within a unit. With regards to the concerns that are expressed with physicians having to move between communities, yes, there's going to be some sacrifices that need to be made. Patients are going to make some sacrifices, and we as the providers are going to make some sacrifices. That's the nature of the beast. We will not be the first health system where this has had to happen. We will not be the first physician who has to drive between 2 or maybe 3 hospitals to provide service. It's being done on our doorstep. It's being done across the country. It's being done south of the border. And that is just how the efficiencies of a new healthcare environment is going to work. The way we anticipate to structure the rest of the service, because we're not just obstetricians, we're also gynecologists. We have a dual specialty, so we do have to do surgery. The proposed plan is to do all the inpatient surgery, the major surgery in the new site. And that the day surgery, which happens to be 86.6% of our work, will be done on either one or both of the other sites. I do not see that there is a need for anyone to move their offices. You will still be providing the prenatal care to your patients in your office as you are. Patients can still go to any of the hospitals to have their ultrasounds done. The patient will need the obstetric unit when she's in labor. That's when she will need the obstetric unit. She does not need the obstetric unit for her 14 or 16 prenatal visits at all. I believe that if we are prepared, both us and our leaders in the Niagara system, to think slightly out of the box, there are ways in which we can incentivize keeping colleagues in communities. We can make it possible for physicians to be in or very near hospitals, which, if that is the case, would also afford us the potential to have coverage of our emergency departments, at least during the working hours of every day. We can also start thinking about, again, looking at our demographic. percentage of physicians who are 60 and above. If any of those physicians were to choose to step away from obstetrics and concentrate on gynecology, why can we not as a system create the possibility for physicians like that to provide their services in one of the other hospitals and maintain a presence in those communities? It is a time for us to think slightly outside the box. Some of these ideas may still be very fresh in their genesis, but it is time for us to start thinking out of that box. The new physical plant. We talked about all the downfalls of the old place. We have a few pictures to show you what our new facility looks like. That's an artist's rendition of a birthing room, large floor-to-ceiling windows with a view over the train tracks and the Niagara escarpment, but we'll focus on the escarpment. This is an actual birthing room. This particular room you will see has a lift for bariatric patients to move the patient from bed to the bathroom, which is on the right on the slide, you can see it, or towards us here if we need to move the patient onto a bed into an operating room. This is a rendition of a pediatric room, a pediatric unit. And this is the actual reception area, I believe, of a pediatric unit. It is certainly a fantastic facility, custom built to do what it is supposed to do for the community. Cost savings. There is a one-time cost saving in the creation of a single-site model of more than $2 million. Some reinvestment is necessary in the creation of some of the services that Eric had alluded to. So the net saving one time of $1.6 million. A two-site model would give you the figures you see there with a significant difference as you can see. So there is certainly at the very least a one-time major saving to be had. There were some discussions around payments to physicians. The numbers explain themselves.
Just to give you an idea of the size of our units, right now the pediatric department does a sizable sort of consultation role in the emergency department as well. So for the entire Niagara Health System across the 3 sites, there are 16,723 pediatric visits. That's about 14.9% of all total visits to the 3 ERs. Out of these, about 12.8% require a pediatric consultation. 87% or so do not require pediatric consultation, are dealt with by the emergency physician in an excellent manner and are discharged home. Out of those consulted, about 10% of the total presenting to the emergency department are admitted to hospital. The point I'm trying to make there is that the vast majority of the patients presenting to the emergency department can be and are dealt quite satisfactorily by the emergency physicians at this time. This talks about the length of stay and occupancy in the various units of the Niagara Health System. Right now we have 23 staffed and operational pediatric beds across the 3 sites. You can see how they're broken up there. Niagara Falls has 8, Welland has 5, and St. Catharines has 10. In the financial year 11 and 12, so until March 2012, which is the latest data we have, you can see that our length of stay is fairly consistent across the 3 sites with 2.1, 1.9, and 2.2. But I'd like to draw your attention to the average occupancy at the 3 sites. As a whole, the NHS, our occupancy rate is only, as you can see in the most recent year, 51.6%. And St. Catharines and Welland are close together in about the mid-60s, but Greater Niagara General Hospital occupancy is only 26.5%. And we still have a lot of staffing costs involved, just in case there are fluctuations when you do need them. In fact, as you will see, Greater Niagara General Hospital has more pediatric beds staffed and operated than Welland, and yet they have fewer discharges, and therefore that gives rise to the occupancy rate discrepancy that you see on there. These sort of issues would be, you know, non-existent, I guess, if we had one unit.
Transportation. I can't remember a meeting that I've had with the NHS about anything that transportation wasn't on the table, and I think that's an issue for more people than just the Niagara health system. But I do think there needs to be a perspective about transportation as relates to obstetrics. For a 3-month period last year, I had every patient who entered our 3 units asked what was their mode of transportation that brought them there when they presented in labor and when they presented for assessments thinking they may be in labor, or when they presented for routine non-stress testing as is done in post-term moms. During the entire 3-month period, on all 3 units, 2 patients arrived by ambulance. None of them were in dire straits. One was in false labor, was assessed and was discharged. The other one was in early labor, kept and managed and delivered uneventfully. Not a single patient arrived by taxi. We are always very concerned about, and we always hear the emotional responses about concerns about moms delivering at the side of the road, moms delivering in taxis on their way to the hospital. I understand those, they happen. They happen in University Avenue, there's chock-a-block with hospitals. They are going to happen, they're going to continue happening. Thankfully, they are few and far between. However, we have seen that precipitous deliveries inside our hospitals, with physicians not present, happens multiples more frequently than moms delivering precipitously by the side of the road or in a taxi. Again, I think that will be addressed with an on-site physician.
Some mention has been made in terms of leaving the pediatric patients presenting to the emergency room at other sites, perhaps not looked after or not have the chance to see a pediatrician if required. I think that point addresses that what I just finished saying before, 88% or so of the children that are presenting to the emergency department right now are not seeing a pediatrician. They're seeing the emergency room doctors who do an admirable job and can continue to do that. As backup, the way we have planned it, they will be able to have access to the pediatrician on call at the new hospital site by phone immediately, of course. And you know, then that pediatrician can decide either the baby or child can be seen immediately if the baby is brought over, if necessary, or the following day in a follow-up clinic, which we're hoping to establish. So there would be fairly quick, you know, access to the pediatrician at this time. Even now, sometimes if it's a call at 1 o'clock in the morning and there is somebody that we get called about by the ER doctor, we don't necessarily rush over and see that patient there and then. We will try and assess to the best of our ability whether that is indeed necessary, and if it is, yes, we will go and see them. But majority of the time, they are either admitted or, you know, told to come the next morning in our office or whatever the case may be after discussion of all the facts. I want to point out that just because pediatrics moves out of Welland and Niagara Falls, it does not mean that the patients can't go there. They will continue to receive care at all our sites, whether or not there's a pediatrician available, and I wanted to just stress that one fact.
A key factor for us, and I am very cognizant of the time, so I'll really try it, because I think everybody's on overload at the moment. Certainly, EMS is a key factor for us. We've had a preliminary meeting a while ago with regards to streamlining transportation of moms to a single site in the event of such a unit being created. And certainly, direct contact between EMS and an on-call obstetrician would go a far way with that. Indicators of success, those are the publicly reported indicators that one will obviously continuously be looking at. In conclusion, I certainly believe that there is a strong case for us to consider delivering all approximately 3,000 women in Niagara in one site. I believe we can deliver a service that is better than the service we deliver now on all 3 sites. I acknowledge again that the service we provide is as good as we possibly can. There's always room for improvement, and we need to strive to improve that service. And more importantly, we need to create an environment where the generation that follows us can provide service. It's not about us, it's about the next generation.